Hey everyone, let's talk a little bit more about gated control theory. It's a bit of an older theory and pain model that we're working with here, but I think it's a really nice way to start giving us ourselves, but also our patients, a bit of a further understanding of how pain works and where we came from as well. Now this model dates back to the 1960s, where we started to recognise the input of the brain and the mind in the perception of pain. It centres on the understanding that pain has a psychological factor, as well as concentrating more on the physiological basis of pain as it interacts with the central and the peripheral nervous system. Now, when an injury occurs, there is nociceptive feedback that is sent from the injured peripheral nerves to the central nervous system. Now, this is similar in older pain theories and models, such as the specificity theory of pain, but in gated control theory, there are nerve gates in the spinal cord. When they're open, they allow that nociceptive signals to reach the brain relatively easy, where we then experience pain. Now, when these gates are closed, nociceptive signals do not reach the brain, or they are much reduced and may not be experienced as pain. Now, many aspects will influence how these nociceptive pain is experienced, and these include the intensity, other incoming nerve signals, including touch, vibration or heat, that whole pinching idea to reduce the pain somewhere else, and the priority on the pain signals due to what's happening at that stage. And this will guide the gate to do several things. Now, one of them is to allow the signal to pass to the brain directly. It will alter the signal due to the expectation of pain. The whole, I can see that it should be painful and therefore it is. To prevent the signal from reaching the brain as another option. But think of the situation again of where a walker crosses the road and stubs their toe versus in their bedroom. Now, if we think about that further, we're walking across the road and we see a truck oncoming. I've stubbed my toe and almost tripped over, but all my brain's thinking is I need to get to the other side of the road. Now that same circumstance, with the same injury in your bedroom, you're going to kick your bedside table and that's going to hurt a lot. But when you're on the road and you can see the truck coming, the circumstance says to keep walking, there is no pain, there is no reason to stop. In your bedroom, you're going to stop, you're going to hold that toe and you're going to rub it because that's potentially going to give you some change in those, gates through our spinal cord in this way. But we do know this is really good in working with a lot of different other theories as well, and particularly with our biopsychosocial model, where we're potentially going to be expecting that pain to be less, more, given our situational circumstances. Now, once the brain receives the signal, it can do several things. It can inhibit or muffle the signal, so decrease it, through the production of endorphins, which is the body's own morphine. Endorphins are created through stress, excitement, and vigorous exercise. And again, exercise is the best medicine. Now, in acute pain, we quickly prompt a motor response. And that's through the thalamus and the cerebral cortex interpreting and responding to remove or reduce the risk of continued pain or injury. That reflex arc. It's very quick. In our chronic pain, we release hormones which can affect stress, depression, anxiety, and that's all through the hypothalamus. But it can also attach meaning to pain, to up or down regulate pain signals due to the personal and social context through the cortex and previous experiences and expectations of pain in that regard. And that's very, that makes a lot of sense. Because really, once we start up-regulating and down-regulating pain signals, that's how we get to chronic pain. I'm expecting to wake up with pain, and therefore I do. Now, consider kicking your toe. When the pain occurs, it is transmitted to the central nervous system through our A delta fibers. They're first and fast pain fibers. And then our C fibers, the slow and continuous pain. So we're going to really start looking at this a little bit further. Initially, that trauma occurs and it's sent through those A delta fibers. Secondary pain is experienced from the C fibers, and you rub your toe, sending further sensory signals through A delta. The rubbing overrides some of that previous pain signals, and those gates partially close due to that perception of normal pressure rather than pain. And that's going to give a reduction of the primary trauma signals, decreasing the pain that's experienced. Now we do this every day, little things, getting our, holding things, hitting our toe, kicking our toe, walking. We're looking at different distractionary pain signals to try and get us through the day in a lot of events there. Now, to close the gates and reduce suffering, we focus on a few different things. 3, in fact: the sensory, the cognitive, and the emotional. Now, to close the gates and reduce suffering, let's focus on those sensory, including increasing activities, short-term use of pain medication, relaxation training, meditation, some of those cognitive factors, including outside interests, positive thought training, distracting oneself from the chronic pain, and then the emotional factors, creating a positive attitude, overcoming depression, feeling reassured that the pain is not harmful, taking control of one's chronic pain in life, and stress management. Now, when we can focus on as many of these as possible and start having that multifactorial approach, we're going to be in a much better position with our pain longer term. And this is what we're talking about. How do we do that? Through some of our effective interventions like psychotherapies, exercise, even if it's a stationary bike, physical therapy and massage, touch, really important there, heat or cold packs, and then we start talking about our shockwave therapy, our laser therapy, our transcutaneous nerve stimulation, dry needling, our pharmaceutical, pharmacological, and then some of our injection therapies as well. And that's what we're really looking at to put that into clinical practice. Educate our patients is a really important aspect. Put all those interventions into place, sure, but we really need to educate our patients about pain. Consider those options mentioned and then put them towards the patient in a way that enables them to create their own change. And once we have the patient owning that change, we're going to find that we get a much better longer term outcome as well. But this has been gated control theory. Please put your comments down. Let's have a bit of a further chat. But for the moment, cheers.